Good evening, everybody. Thank you very much for joining us here at Melbourne IVF on a cold Melbourne evening after such a lovely weekend that we're all able to enjoy here in Melbourne. My name is Jim Tsaltas. I'm one of the gynecologists and infertility specialists at Melbourne IVF. My other hat is I work at Monash University. I'm Professor of Endometriosis and minimally invasive surgery at Monash University and Monash Health. So I'm very privileged to wear two hats in my career, and both Melbourne IVF and Monash University have been big parts of what I've been able to do for my patients. Tonight I've been asked to talk about genetics, and particularly related to fertility and infertility. I would thought that I'd spend about 10 minutes, not to bore you, to give a bit of an overview on this very, very big topic. I thought I would start with talking about preconception screening. Many of you will be aware, or may well have been offered or already had some preconception screening before even starting to try and get pregnant, or the first time you may have actually had this discussion with your doctor is when you saw your fertility specialist. Just a bit of a background. Most people who are planning a pregnancy will go to their GP and have routine screening, and we know all about rubella and chickenpox screening before trying to get pregnant. We talk about preconception, folic acid, and we also get a full blood examination. Many of us don't really ask why we're having a full blood examination, but that's really the first genetic test that you have, and you're not aware that you're having it. So what are we looking for when we're doing a full blood examination? We're looking at your risk of being a carrier for thalassemia minor. And then if you get a particular group of blood parameters on your full blood, you will then have further testing for thalassemia screening. And then if you are a carrier, your partner will then be followed up for their carrier status. I'll talk a little bit more about the genetics and the risk of both partners being carriers in a moment. The next group, particularly those of us who live in Victoria, is the Prepare test. And you may have heard of that, and that's performed through the genetic services through the Royal Children's and also through our laboratory at Virtus, and we work very closely with the two laboratories. And the initial group of testing, and the one that you'll most likely be offered, is that for cystic fibrosis, Fragile X, and spinal muscular atrophy. If I can expand on those a fraction and why they're offered. Firstly, in Australia, 1 million Australians carry the cystic fibrosis gene. So that's 1 in 25 people. So it is the most common genetic issue that is actually seen at children's hospitals at birth, and then obviously is an ongoing issue for children and then as young adults. The second is Fragile X, and 1 in 250 women will carry the Fragile X gene. And that's relevant in that it will cause severe developmental and autistic type behaviour in children. If you look at a cohort of autistic children who may be sharing the same learning group, support groups, that they will have all, most of them, if not all, will have been tested for Fragile X as a potential reason that they have this type of behaviour. They're different groups, autism and Fragile X children, but they are. But the Fragile X is an inherited disorder. And the other is spinal muscular atrophy, which 1 in 300 Australians carry, and that causes severe muscular damage and death by age 2 to 9. And some of you will have started to hear about Mackenzie's mission. The Federal Minister for Health, Minister Hunt, has been talking about the family where a young boy called Mackenzie died of spinal muscular atrophy, and he's been pushing nationally to actually have the 3 genetic tests, which are obviously, as I mentioned, cystic fibrosis, Fragile X, and spinal muscular atrophy, being screened for nationally. And currently there's a large national project called Mackenzie's Mission to actually look at the carrier status through the community of these disorders, and also 700 other gene defects. And hopefully that will be rolled out to be free to all Australian couples who are planning to have a pregnancy at some point in the future. And we at Melbourne IVF and Virtus are the partners that, if with the government, that if a a couple are carriers for one of these disorders, that we would then look at genetic testing and pre-implantation genetic screening of the embryos, which I'll come back to in a moment. These disorders are autosomal recessive disorders. What does that mean? That if you're a carrier, you are absolutely fine with being a carrier. It has no effect on you as the individual. However, if you actually pass on the disease, so for example, if a couple are carriers for thalassemia, or if you're carriers for cystic fibrosis, then your child has a 1 in 4 chance of actually having one of these, of having these disorders, and actually having a significantly impact on their quality of life, and in fact a significant shortening of their life expectancy. Fragile X is carried on the X gene, obviously, so a woman can be a carrier, but then unfortunately she has a 1 in 2 chance of passing it on to her male offspring. So really, I started the discussion talking about these disorders in which we can now actually request a test before you actually start your journey to get pregnant. Certainly when I see my patients, if they're struggling to get pregnant, they've been referred to me, I would have the discussion with the patient if they've not already had these investigations. For 2 reasons. I think it's important that we know what our carrier status is for these very important genetic disorders, because we can then have appropriate counselling as what options are available to us when if we were to conceive naturally, or if we needed to move down IVF. So if a couple was found to be carriers of a disorder and they were pregnant, there would be specific counselling about whether the pregnancy would be tested, and if the test was positive, what would happen and what the desire of that couple would be for that pregnancy. Moving forward with where technology has taken us, if we actually know a couple of carriers before they get pregnant, or even before they try and get pregnant, when they want to get pregnant, or if they're moving on to more advanced treatments such as IVF, we can actually test the embryos to actually exclude the embryo that actually carries the full complement of the genetic disorder. How did genetic testing come to be? Well, firstly, it started for very specific disorders where either a child would die shortly after birth, or within their childhood or teenage years, or even with the disease known as Huntington's chorea later in their adult life. So that as we started to understand more about the genetics of certain disorders, that genetic testing was offered for very specific gene disorders to help a couple avoid having another child that may actually pass away early on in their life, and even stop the inheritance of the disorder down through the generations. The next group of patients were couples who conceived easily, had no problems in conceiving with spontaneously, but unfortunately went on to miscarry on a number of occasions. And once other potential causes of miscarriage, whether they be anatomical, so uterine disorders, or disorders of immune factors or clotting factors, were excluded, then genetic testing was offered, not because we were concerned about whether you would get pregnant or not, but to actually see the types of embryos that were created. And we've certainly found that some couples will create genetically abnormal embryos time after time after time, and miscarry on numerous occasions before potentially having a successful pregnancy. The third group are women who are already undergoing, or couples I should say, who are undergoing IVF treatment where they've actually failed to actually get pregnant. And we know, and many of you may have already had investigations to see if there's any immune factors, chromosomal factors, or clotting factors that may impact on your ability to actually get pregnant and hold a pregnancy. And once these factors have been excluded, then we can actually look at the embryos to see if there's an embryo factor. We have to think about, how do you form, firstly, a sperm and an egg? And it's a very dynamic process. We all have a 46 chromosomes. And when we form a sperm or an egg, we have to split those chromosomes to 23 pairs. And then that's where some of the problems can occur, particularly for more significant major chromosomal factors. But obviously with gene defects, there is a single gene within millions of genes within the chromosomes. So certainly this technology is quite extraordinary. When we look at genetic testing, it's done on a very high grade embryo on day 5 or 6, and even occasionally, if the embryo is a little bit slow with development, on day 7, but usually nearly all embryo biopsies are done on day 5 to 6, and then the embryos are frozen until the results are obtained. So that's a very brief snapshot of genetics, and certainly the advancing and evolving field of genetic testing within both IVF, but also in the broader community for couples that carry a significantly lethal genetic disorder. So I think I've gone a few minutes over what I said I would go. I've always felt that it's important that I try and answer your questions as our patients. And I have got a number that were already sent through before we started on this Facebook webinar meeting, and they weren't specifically related to genetics, but I'll try and answer them, and then I'm happy to answer any questions on any topic of fertility, but particularly related to genetics, if that's your area of concern this evening. So firstly, the question was, does a low AMH level cause fertility issues? And the couple that sent this in said that the female, they've been trying for 10 months and the female partner is 27. AMH is anti-Mullerian hormone. It's a hormone that's produced by each of your eggs within your ovary at a tiny, tiny, minute level. So the AMH, or the anti-Mullerian hormone count, is a representation of how many eggs you've got. And certainly now this test has been around for almost a decade, and it is a marker of our ovarian reserve. However, it is not a representation of your ability to get pregnant. How I present it to my patients is that it started as an IVF test, in that in the past, when you were undergoing IVF, ideally we want to try and get 10 to 15 eggs, and we would actually use a dose of medication based on your age and your height and your weight. And somebody hit the sweet spot. Many people hit the sweet spot of 10 to 15 eggs, but some people are overstimulated. They've got 20, 30, 35 eggs, and some women only got 2 or 3 eggs or 1 egg, and always used to ask, what's wrong with us? And we used to call that patient the poor responder group, and the patients that made too many eggs were the overstimulated group. Now we know that the AMH will actually represent how you're going to respond to IVF, so that if your AMH is extremely low, you'll get less eggs, and if it's very high, you'll get more eggs, so we can adjust the dosage accordingly. But back to the actual point of the question, will it affect my ability to conceive? No, because people's AMH, you are born with your level of AMH and your genetic predisposition to have a certain amount of eggs when you're born, when you mature, and then moving on to menopause. Obviously, ovarian surgery will actually change that, but that's a whole different topic of conversation. So I tell my patients that if your AMH is low and you're thinking with your partner about having a baby, that you should stop thinking about it and actually start considering trying. So a low AMH creates time pressure that is a little bit unfair, but unfortunately it's a reality of what we face. If your AMH is low, then, and you've been trying for this amount of time, particularly at 10 months, then you should be looking at IVF, because your AMH is only going to drop, and you want that narrowing window to stay as far open as it can, particularly at 27 if you've got a low AMH, that we want to try and do as much as we can to try and for you to try and achieve 1 pregnancy, so that you have an opportunity to actually have a second pregnancy in the future. So the sooner we act on that, because there are other reasons why you're not getting pregnant, but the AMH helps determine how quickly we should act on getting further treatment. On the other hand, if you have a very high AMH and you're 35 and you've been trying to get pregnant for a year, the high AMH shouldn't lull you into a false sense of security that you can wait forever to have a baby. It just represents how many eggs you've got. Your eggs, apart from actually dropping in their number, will drop in their quality as we get older. So the next question was, how much does weight play, both for the male and female, helping or hindering conceiving? We all know what our ideal BMI would be, using a very simple equation of our heights in centimetres and our weight in kilograms. And ideally, our BMI should be between 20 to 27. And then particularly when it gets over 35, then the BMI will compromise, one, the ability of an embryo to implant in the uterus. It will halve implantation rates, both for natural conception and also for IVF conceptions. But also it will affect the sperm quality. So certainly men whose BMI is higher than it should be would need to look at lifestyle modifications, as do all our patients, to look at how they can actually best get as fit and as healthy to try and conceive. And that's where the importance of understanding your weight and your BMI, and for all of us to try and strive to stay as close to our ideal BMI, not just for conception but for our long-term health, is very important. The next question was, does having premature adrenarche as a child have effects on fertility later in life? There are different reasons as to why that may occur, and I think that's a very specific question that only your specialist can answer. Certainly if somebody is concerned about certain elements of when, sorry, that was just a text that came in that closed off the phone, that you can talk about if people are concerned about various aspects of their pubertal development, maturity. That's something that really should be addressed and discussed at an early age, so people can actually plan when they should conceive and what avenues are available to them. Someone else asked, spotting for a few days before ovulation, should I worry? That can be quite normal, but there are a couple of anatomical issues and issues that may actually cause spotting premenstrually. So firstly, you should make sure there's no polyp in the uterus or a small fibroid that's protruding into the uterus. Not only will that can cause premenstrual spotting, but it can also cause bleeding at other times of the cycle. The other two areas which I have a big research interest on is adenomyosis and severe endometriosis, in that both these disorders can cause premenstrual spotting. Having said that, premenstrual spotting can be normal in some women, and certainly the tricky part is when to work out what is my true day one. And for all of us to be on the same page, we would say, as our nursing teams would say, and our other medical practitioners, that we should focus on the heaviest day of bleeding as being your day one. However, if you do have a prolonged period of premenstrual spotting, that's something that you should investigate further with your specialist. So they're the questions that I had passed on to me, and hopefully given those patients and their partners some guidance as to how to particularly proceed. But certainly in the last 5 minutes that we've got remaining, I'm happy to answer any further queries that you may have. Okay, so I've been told, Julie's kindly sent me a text that in the chat box, more chat. Okay, thank you. The next question was, is genetic testing an option after falling pregnant? Of course. So if you were pregnant today, your obstetrician would actually talk to you about the prepare test, if you've not already had it done, to actually look at your carrier status for cystic fibrosis, Fragile X, spinal muscular atrophy. Logically, you would have had a thalassemia screen because your GP would have done that. But again, that would be a test that your specialist, your obstetrician, would look at. When the laboratory knows that you're actually pregnant, they will try and fast track the result. It needs to be done in the first 3 months of the pregnancy, because if you're a carrier, then your partner needs to be screened, and then you've got to have enough time to get all the results to make a decision as to whether you're going to have a CBS or an amniocentesis to check for that specific disorder. When we also look at genetic testing, I'm sure when people are pregnant, they're looking at specific Down syndrome screening, and there are very advanced early tests now that your obstetrician will talk about to actually screen for Downs, and indeed other specific chromosomal disorders that are not inherited. Down syndrome is a random event, as are other disorders, while when we talk about a specific gene disorder, it's a particular gene, the gene that we carry, that can be passed on to our offspring. So would a couple be advised not to conceive naturally if both partners are identified as carriers? No, there will be. What would happen if a couple were identified as being carriers is that the genetics team at the Royal Children's or at Monash Children's would actually meet with the couple and talk to them about their option. And the option may well be that the couple tries to conceive spontaneously and then has a appropriate testing during the pregnancy. But obviously those couples may also make a decision, if the pregnancy is abnormal, that they will continue with the pregnancy will continue with the pregnancy, or potentially terminate the pregnancy. Very decisions that sometimes are easier to make before you actually get pregnant. Obviously, other couples would then move forward would actually move forward with IVF and genetic testing. So how long does genetic testing take? Usually the results take around about 3 to 4 weeks to come back. So it's something that needs to be done ideally before you get pregnant, but obviously as soon as you're pregnant, to start talking about these tests. At the moment, the Mackenzie's mission tests that are being done through the New South Wales and Victorian government do take longer because of the delay in Australia Post. And that's one of the shortfalls of obviously trying to do this at a time when there's such enormous strain on our postal service. So that can take up to 8 weeks. So the next question is, does PGT testing for Down syndrome? Of course, PGT or pre-implantation genetic testing can look for specific gene disorders, but for example, cystic fibrosis if you're a carrier, but it also looks for the chromosomal count. So it actually firstly looks at whether we have 46 chromosomes. So as we know, Down syndrome will pick up, it is an extra 21st chromosome. And the next question along that same line is, how accurate is PGT? It's extremely accurate. We would quote an accuracy rate of above 99%. But because it's not 100%, we would then advise our patients that if we've put an embryo back that we've told them is genetically normal, that there are many non-invasive tests that they should also consider, because not all abnormalities that children may have are genetic. So there is firstly the non-invasive maternal blood screening for Down syndrome. There's also the very highly sensitive nuchal folds, skin fold thickness, and screening for Down syndrome. And then there's obviously scanning that you do at 18 weeks for other skeletal and cardiac anomalies that are not related to any genetic screening. So we would certainly say that it's highly accurate, but there are now many non-invasive tests that would actually give you further reassurance that your baby doesn't carry these genetic disorders. Now, there are certainly some people who do not want to have any further testing once the pregnancy is alive and progressing, and they would rely on the PGD testing, and that would be something that they would discuss in great detail with their specialist, and we've certainly all had a number of patients who fall into that category. So IVF and miscarriages, is PGTA a solution? Certainly if I had a patient who conceived with IVF but then kept miscarrying, then we would obviously look at, are there any structural issues, so anatomical issues? Are there any issues that are immune related? And then, yes, even if you found those issues, I would think that you would then also talk about embryo biopsy, particularly in that group, to try and reduce a genetic cause of miscarriages. Because even if you correct the anatomical causes and the immune causes, if you've had a number of miscarriages and then you happen by pure random chance to put for an embryo that is genetically abnormal to go in and you miscarry again, you're then stuck again at the start of the conveyor belt as to what's the cause of the miscarriages. The next question is actually a great question. They're all great questions. Is, can sperm be genetically tested? It would be wonderful if we could actually test the egg or the sperm. Unfortunately, as you all know, the sperm and the egg are only one cell, and it only has half the genetic complement. If we actually need to take that cell out to biopsy it, then there's no cell left, so there's no actual sperm or an egg left. Why do you test the embryo? On day 5 to 6, the embryo will have almost 300 to 400 cells, and these cells are multi-potential and represent the whole embryo, and you would take some of these cells out, and then it has no impact on the embryo itself, and they can then be tested. The next question follows on from that is, can an embryo be damaged by embryo testing? We would quote the chance of an embryo being damaged by the extraction of those cells to be just under 1%. So it's not zero. So we certainly have been doing this for many years, and we know exactly what our statistical rate and the chance of an embryo being damaged. We're very, very fortunate that because we've been doing this for such a long time, we have such skilled embryologists who can teach other embryologists to perform the procedure at the same level of expertise. So the next question is a question that I'll read out, that my family history shows a strong correlation to intellectual disability. We've screened for Fragile X and are not carriers. Is there any other genetic testing that is available to determine if the disability is genetically passed? There may well be. I'm not an expert, other than we do see many people with Fragile X. I'm not an expert on other genetic disorders that may cause intellectual disability. If you were my patient, I would actually directly refer you on to the team at the Royal Children's Hospital, to Professor David Amor and Professor Martin Delticchi, who are the heads of genetics there, who would actually be able to look at answer this question for you. And if there is other, even because Fragile X is very commonly carried, but if there are other very rare genetic carrier status, they will then, and it's picked up, then of course, once you have the gene identified, you can create a marker for that gene and test specifically for that gene disorder. So thank you very much, everybody, for your attention this evening. I know it's late, and I've certainly been very privileged and honoured to be able to spend this time talking to you, and hopefully giving you some further information about this very, very important topic that is playing a greater and greater role in the management of our patients. So thank you very much. Good evening, and enjoy the rest of your night. Thank you.